Guy St Thomas's, I sit on the Hospital Pharmacy Transformation Programme Board, where my responsibility is for education, training and development. What this means is that I'm responsible for developing the pharmacy workforce in line with the recommendations by Carter. The Carter recommendations include increasing the number of clinical pharmacists on the wards, and also the number of clinical pharmacy technicians to support the clinical pharmacists. My role within Carter is to ensure that the workforce that we developed is adaptable, flexible and competent to meet the needs of this future service. The role that I have in my work stream is to liaise with other work streams such as clinical pharmacy, operations, which includes dispensing pharmacists and dispensing technicians, and production, which includes technical services where we have lots of pharmacy technicians and lots of pharmacists. This is underpinned by working alongside the Medicines Information and Governance workstream to ensure that we have a degree of educational governance within our staff development. Not to mention IT workstream to ensure that we have staff who are IT competent and can deliver the digital strategy that the NHS needs going forward.
And I'm the Chief Pharmacist of the Luton and Dunstable University Hospital, a typical DGH with about 700 inpatient beds. We provide a standard pharmacy service, the usual mix of patient-facing and non-facing roles. I've always seen our number one core responsibility to ensure the right medicine is in the right place at the right time. You can have the most brilliant clinical pharmacy service, but if the medicine is not available, it is to no avail. The recent Carter report on productivity and performance has flipped that on its head, and it is clear that going forward, our main role in hospital pharmacy will be the patient-facing medicines optimisation role. The scale and the scope of the transformative ambition in the Carter report now needs to be translated by each trust into a hospital pharmacy transformation plan. The idea being, through consolidation of non-clinical activities, we release resources to enable us to maximise our patient-facing medicines optimisation service. It is important that we do this without compromising the efficient and assured supply of medicines.
Accelerated access review, and this is looking at how we ensure that the NHS is a good receptive environment at sort of various stages of the development pathway for new medicines. So for some new therapies, we may not know at the point they get their marketing authorisation exactly what their real world impact will be, and rather than just have a kind of binary yes, no, nice type process, what we're doing increasingly, we've done this now with oncology agents, cancer drugs, is saying you've got up to 24 months where we will fund the use of the drugs so that we can see how patients actually benefit. Could we expand that beyond just the cancer area? Potentially we could. And then when we know the answer, the yes, no, maybe answer at the end of that period, we obviously want to ensure that there's faster diffusion of those therapies across clinical practice. None of which is to deny that there aren't very real pressures. Of course there are. But what this country needs is a strong life sciences industry with a receptive NHS. And I think there is a win-win there if we can help take cost out of the drug discovery process, and as a flip side, ensure that patients then get faster access to the best drugs.
Personalised medicine's a bit like getting a made-to-measure suit rather than just something straight off to pay. If we can better tailor the knowledge we have about an individual, we can understand how they are, particular nature of their body and physiology, we can better tailor the treatments to them, and they get a better outcome at the long run, which is a great gain for the NHS. It should save the NHS money by getting the right treatment at the right time. It should also avoid bad side effects and drugs that don't work for people.
We've also seen so many advances already, haven't we, in cancer treatment, in the ability to test for a gene in cancer and then give patients the best treatment first time. So we get better outcomes, we save money, but it's also less side effects in some cases for patients.
Yeah, and there are lots of the common diseases. I mean, cancer is a big area for personalisation. Diabetes is another area for personalisation, and kind of going forwards, it'll be looking at areas like mental health, where we know there's a tremendous variation from one person to another in terms about whether the drugs work or don't, and we're still not quite sure why. So it's a great learning exercise. But I think personalised medicine is going to touch everybody's lives in the NHS. It's not just the specialist teams. It's, you know, for everybody right through to the front line of primary care. Kind of in the same way that knowing about microbiology and knowing that and you know, bacteria matter in hospitals and healthcare settings, from whether you're the chief executive or the cleaner. You know, genomics and personalised medicine will touch everybody's life in that way. It's important that everybody has at least some understanding about the area and how they might use it in their kind of sphere of work.
And how far away are we from this actually benefiting patients?
Well, it's already benefiting patients in some different areas. For example, cancer, we've seen huge advances.
Outside of cancer?
Outside, I'm really good example. You know, we're seeing great advances in areas like children with rare disease. So you have a child with rare disease, you go through years and years of tests and diagnostics, and we've had children from some parts of the country who they've eventually got diagnosis and said, just change this child's diet, and suddenly their epilepsy gets a lot better. You know, people have got kind of genetic high cholesterol. You can give them drugs to stop it, and that stops them from having heart attacks before they're 50. And say a saving to the system, but a huge kind of transformation of people's lives, and the human cost mustn't be underestimated.
And the avoiding adverse drug reactions with HIV.
Yeah.
Some of our treatments now, in the past you would have had treatment, standard treatment for HIV, and you may have had a bad reaction to it. Now that we can check the gene that causes that, we can prevent that happening. And that also saves a huge amount of money. How many admissions did you say in a hospital?
Oh, well, they reckon 1 in 15 hospital admissions, 1 in 15 people going through the front door of a hospital is because they've had a bad reaction to their drugs, and about 70% of those are preventable. So actually, if we can use modern diagnostics to stop those sorts of things from happening, that's a tremendous burden on patients and on the service that we can list.
And what about with regards to the cost of new medicines? So for people who don't understand, explain that in layman's terms. So it's largely stated that personalised medicines, while they're revolutionary, they are going to be extremely high cost, and therefore perhaps only the larger pharmaceutical companies will be able to manufacture these new types of treatment. Is that inaccurate? And if it is, can you explain what is the accurate view?
I think it's easy to think that personalised medicine will just be about generating really expensive drugs, and that isn't the case. As I say, sometimes for things like in diabetes, you can end up using cheaper, easier drugs to get the right patient diagnosed with the right way and to the right treatment.
So the 100 Genomes Project, just tell us a little bit about that, where we're up to and what we expect and anticipate in the next 12 months.
The foundations for personalised medicine in the NHS are the 100,000 Genomes Project. So there's been a network of expert centres, the NHS Genomic Medicine Centres, set up and down the country, each of them serving about a population of 3 to 5 million. And all the hospital and health services within those regions are part of each genomic medicine centre. So this is establishing the infrastructure that will allow us to build knowledge about personalised medicine.